So we'll have 5 minutes of reading time before starting the case discussion. Again, your examiner will be responsible in case discussions to manage your time. Your time starts now. Case 2. Patient record summary. Name, Alex Williams. Age, 45 years. Not Aboriginal or Torres Strait Islander. No known allergies or adverse reactions. Current medications, metformin 500 mg BD. Past history of type 2 diabetes mellitus diagnosed 5 years ago, managed with diet and medication. Hypertension diagnosed 3 years ago, controlled with lifestyle modifications. Social history, married, lives with wife Maria and 2 children. Occupation, high school teacher. Family history, father, type 2 diabetes and hypertension. Mother, breast cancer. Smoking, non-smoker. Alcohol, 1 to 2 standard drinks on weekends. Immunisations and preventative activities. Annual influenza vaccine, last administered 6 months ago. Colonoscopy, performed 3 years ago, normal findings. Scenario. Alex Williams, age 45 years, presents with concerns about his recent health. He mentions experiencing increased fatigue over the past few months, which he initially attributed to the demands of his job and family life. However, he's also noticed occasional tingling in his feet and a recent unintentional weight loss of about 5 kilograms. This is over the last 6 months, despite no significant changes in diet or exercise regime. Alex is worried these symptoms might be related to his diabetes and is seeking advice on what steps to take next. He's particularly concerned about the potential complications of diabetes and is eager to discuss any necessary tests or lifestyle adjustments to better manage his condition. All right, your reading time is up. Your case time has started. What initial assessments and investigations or examinations would you perform for Alex given his symptoms and medical history?
Initial examination and investigation.
Yes, please.
Okay, for examination, first of all, I will explain to the Alex what I'm going to look for, take a consent, and then wash my hands and start from the general appearance, how the patient look like. Is it like anemic look like or jaundice look like? So, and then I'm checking the vital sign, the pulse rate, is it heart rate is high or blood pressure is low or even high, if controlled blood pressure or not, and then checking the temperature, is there any chance of the fever, chance of the any oxygen saturation low or not. Then I can check for the respiratory and BMI and compare with the previous BMI. Then because of the fatty, it can be everything from head to toe. I will have a look about eyes, whether it's any conjunctivitis, any jaundice. Then I'm going to check for thyroid gland, if there's enlargement, if I can see, or nodules, if I can find out. Then I'm going to the cardiovascular, check for any chance of the AF, arrhythmia, sign of heart failure in JVP is high. For heart failure rule out, then checking for the lungs for any like crackle in the base of the both lungs for the chance of heart failure, whether it's clear both sides or crackle or chance of pneumonia or infection. Then I'm going to check the abdomen for any distension, for any mass or organomegaly, for find out whether patient has any mass or any tenderness, if I can find any like a gastritis or pancreatitis or even polylithiasis sign, polylithiasis sound, and enlargement of the spleen or liver, if there is any chronic issues with hepatitis, if the patient has. And then quickly I checked the neurological examination about basically the peripheral, about the both legs, if the patient feel about so tickling in the legs, I guess, tickling in the feet, yes. Then I'm checking the reflex of the knees, and then checking the sensory, and then yes. So for investigation, I would do the sugar test in the an ECG as an office test. I can check the urine MCS if the patient has some symptoms, for just ruling out any proteinuria, and then checking for the ketone or sugar as patient with diabetes. Then I'm going to investigation, explain the patient, and then take account for full blood count, ESR, CRP for infection, inflammation, anemia, iron studies, B12 and folate, thyroid test, and also HbA1c, cholesterol lipid profile, then LFT, EUC, and FOBT. The patient is due for 3 years ago. At the moment, if the patient has some background of the sexual health issues, I can add STD and HP, hepatitis B, and also HIV, if give me some like history. Otherwise, I will stay on this one.
Okay. Question 2. What are the potential complications of diabetes that Alex might be experiencing based on his symptoms?
What is the complication of diabetes he might experience? Okay, it's a peripheral neuropathy by not controlling the blood sugar properly. So also, if the diet is not managed properly, it might be also can be affected by the chronic kidney disease. So it can be like problem with ophthalmology, like a problem with optic nerves, or any it's called like hypertensive hypertensive ophthalmology, if I'm not wrong. I mean excessive exudate in the eyes, pale disc, optic disc. So it is. Can you repeat that question again?
Yeah, sure. What are the potential complications of diabetes that Alex might be experiencing based on his symptoms?
Based on these symptoms. So other things can be problem with sexual life, erectile dysfunction because of the neuropathy can do that. Can be problem with incontinency, any neurological part in the lower legs, or imbalance. I haven't checked the examination. I could check balance as well.
Question 3. How would you counsel Alex about lifestyle modifications to better manage his diabetes?
How we can change lipidem to okay. So first of all, I would give some information about low carb diet, and then also explain about high fiber, like a more cereal, have some like a low GI food, like a pasta or brown bread, or even rices, rather than something like a sugary or snack. And then explain about have a 5 serves vegetable, 2 serves fruit per day if it's the ideal, but it depends on her and it depends on him. And then I could offer to see dietitian in terms of the good diet plan management, and explain to just come frequently to see as per I put him on a GP management plan and team care arrangement. This is the diet management. Then I would explain about what is the plate serves for the diabetes. Could be how much the protein should be, like a 1/3 carbs, 1/3 protein, the half of 1/4 carbs, 1/4 is protein. The half of them should be a vegetable. And give them some leaflet about diabetes, and give them from the NDDS website. And Better Health channel also. Life diabetes. And about the life, you just about a diet or about lifestyle change as well?
So the question is, how would you counsel Alex about lifestyle modifications to better manage his diabetes? Mm-hmm.
Also need to increase the exercise as well. So I would say 150 to 300 minutes per week, moderate intensity, 60 minutes. High intensity exercise would help him per week. Then again, I will offer to see the exercise physiologist in terms of just make a tailored plan for him. Then occupation, high school teacher. For example, I give some tips what he can do in terms of in the daily lifestyle. Just if you go by the car, try to use the bicycle. Just give them some idea what change he can do. Then he's not a smoker, drinks on the weekend. He's not an unsafe alcohol either. So drink more water. Try to just follow the whatever diet plan I gave, and also connected with the diabetic educator about to have a better picture of all the diabetic management plan, and give some idea if needed to change anything in the medication. That would be great.
Question 4. What medications might need to be adjusted or added or considered to Alex's regime, considering his current symptoms and history?
Okay, he's on metformin, 500 milligram BID. So I don't have access to the blood sugar, how much the blood sugar is, but as far as the patient doesn't have a hypoglycemia, then kidney function is it's more than like a 30 GFR. So I would consider to increase the dose of metformin to 1 gram twice a day if the patient can tolerate it, no symptoms of the bloating or diarrhea or nausea, vomiting. Then review again the patient in for example, 2 weeks time to how cope with the medication. And then educate the patient if any vomiting happens. So stop the medication and then start it after you feeling better. If again, if it happens, you please come back. I can change your medication to something like a sulfonylurea or thiazolidinedione, thiazolidinediones. Also, there's high blood pressure. So it depends on what's the blood pressure level is. If it is high, I would consider to start on some prindopril or coversil ACE inhibitor. Considering the cardiovascular risk, if it is high, I would consider to start on a statin as well. Yeah.
Question 5. What preventative measures should Alex continue or start to reduce his risk of further complications?
What management you can do for decrease complicated? Sorry, just repeat that question.
Yeah, sure. Question 5. What preventative measures should Alex continue or start to reduce his risk of further complications?
Okay, so first of all, have a routine follow-up for his diabetic management. For example, at least 3 months to come here for the checking with the chronic care nurse and the GP. I also have a 6 months to check the food with the podiatrist, or even the clinicians can do that. Also have a yearly optometrist check for the eyes, and also if any issues, then we can arrange a referral to the ophthalmologist. Then for kidney function, if the kidney function is stable, we can check it yearly, or if the sugar is stable, we can check yearly. Otherwise, we do recurrently accordingly. For example, HbA1c every 3 months. And then yes, for general blood tests, I do recommend a kidney liver function 6 months until get stable. Then other preventive measurements is just coming for the vaccination yearly, which he does. And if it is not up to date with the COVID vaccine or a pneumonia vaccine, we can arrange that one as well.
Excellent. Question 6. How would you address Alex's concerns and provide reassurance about managing his condition?
Sorry?
How would you address Alex's concerns and provide reassurance about managing his condition?
Address concern and provide reassurance. Okay, so first of all, I would say, first of all, I need to know what the blood test result. If nothing urgent, which we can arrange it, we can manage it outpatient. So I would consider about good explanation about what's the fatigue and what could be the reason about differential diagnosis, which I ruled it out by my blood test and examination, and most likely is related to diabetes, which is not well controlled, and high blood pressure. So then I help him with some motivational interview, and then I ask him what you can do, this is the ideal stage, so what you can help yourself to come to, then what's your goal in terms of the fatigue? So do you want to just have some energy to work, or you just want to come to the a normal healthy stage, which is ideal as a BMI less than 25. I'll give some idea about in general health, and then and address whatever concern, explore what is his agenda about that to cover that one, and then just empowering the patient that he's able to do that. Even if it's the fatigue, gradually graded exercises by physio can help to come to the point, and then just make him that it's not a one-night treatment, it's just be patient, and then we follow up, and if there is any concern anytime, if there's any red flags such as a fever or any new symptom which scare him, or any severe pain in the abdomen or lightheadedness, faint syncope, so you please come back urgently or go to the ED, and I will arrange to give me after hours phone call to be accessed and give some reassurance for the Alex. I give some leaflet and reading material about the fatigue, diabetes, what could be the symptoms of the neuropathic diabetes. It is, I will tell that it's not coming back, but we wanted to stop it to not get worse. This neuropathy, if it is annoying by sleep, if it is annoying by lifestyle, we can arrange some medication like a government to help you not feeling worse, not feeling bad during the sleep, make you calm down. But necessarily, this is the injury done, and it is not reversible. Just we can stop it to not get worse.
Excellent. Is there anything else you would want to add for this case?
Yes. question two for examination, I forgot about a balance gait of the patient, sit to stand test,
And
Romberg
that is
test
time.
also. So,
Well done, well done. So, very well done. And I can see this is something that you know a lot about. I think you really conveyed that you are seeing lots of patients. You are obviously very comfortable managing diabetic patients as well. And this is one of those things where it's a race against the clock to get all that information out. How did you feel you went? Did you feel like you were flustered, or how do you feel?
because it looks like walking on, because I don't know where I'm going. Is it really fatigue, just diabetes, or just assume that diabetes? Or I'm going to the right way or miss something?
Yeah, no, perfect. So this is a sneaky case, and you will occasionally see cases like this where they try and give you something that's very common, that we see all the time, that we're usually very comfortable managing, like diabetes. But then they tweak it and add a few bits to make you say, oh, could there be something else there? And I think very appropriately you screened for thyroid, you screened for iron. I think a lot of people forget that profoundly low iron stores can give you lots of abnormal neurological findings. Don't forget things like checking calcium levels as well. I don't know if you specifically stated that, but electrolyte imbalance is another one you could have a look to as well. And you acknowledged as well, yes, he's had a recent colonoscopy, but you said a few times you'd look into the bowels as well. Obviously, we've got a patient here who's losing weight, and we have to consider all kind of diagnoses. So you kind of touched on that. I would probably just, as a throwaway line, say somewhere in there, of course, we have to be worried about malignancy given some of those symptoms. And I think that just ticks the box for the assessor. But I think you did kind of touch on it enough times at multiple time points as well that as the examiner I could see that was one of the things that was obviously in the back of your mind. So I think probably the one thing I would recommend to you for kind of preparation moving forward is, do you use like a template, or do you have like a structure that you kind of tick through as you're going along, or?
Not. I have a template, but I haven't used it, to be honest. No. Do you have any template you suggest me, or?
Yeah. I'll pop in on the channel. I'll post put a post in with a couple of different resources. So I think a couple of times that did come across that you weren't kind of checking through a checklist so much as just whatever was coming into the mind, you were getting it out there. It was all fantastic stuff. It just did come across as a little bit unstructured. And so you lose some of the flow. Sometimes you would jump back and forth a little bit. And again, that's okay, but to just really show, how polished you are and how prepared you are, that's one thing you could look at. And practice with it as well. Some people find that if they're going through a checklist, they feel more robotic and they don't think as freely. That you're more trying to make sure you do your checklist as opposed to thinking as you would in a clinic. So see if it is something that works better for you or if it works against you, and that's just practice, I'm afraid. If we go back to question 1 in terms of what initial assessments or examinations, this is intentionally a big question because this is partly here to kind of assess how you structure your responses, how you deal with that level of uncertainty. And so one thing that can save you a bit of time is instead of stepping through kind of the Talley and O'Connor style, I'm looking at the hands for this, you can just say I would do a respiratory or a cardiac examination, checking for signs of ischemic heart disease, noting his hypertension history. And so you're essentially covering all those bases. We know what you're looking for. And obviously any of those other little things you would pick up along the way. It just helps speed things up a bit and saves a lot of time. The investigations, you absolutely smashed. Well done. You ticked every single box that I had listed there. One thing you can consider for diabetic patients would be some of the continuous glucose monitors. They're not subsidised at the moment, so there are patient costs, but it would be something you could talk to the patient if they're concerned about their diabetes. They could consider a continuous glucose monitoring device. And you didn't mention it here, but you came back and mentioned it later. So you would still tick the box, referral to ophthalmology or optometrist for regular eye exams. And so as part of this examination, you would also do fundoscopy just for assessing signs of diabetic retinopathy. Question 2, you ticked some of the boxes, unfortunately missed a couple of them. Really, this is they just want you to regurgitate through the complications of diabetes. There's your diabetic neuropathy, which is the tingling sensation he's getting there. Poor glycemic control, with fatigue and weight loss being prominent features. Diabetic nephropathy, with the unintentional weight loss, can again be a sign of renal involvement. And cardiovascular disease, given the history of hypertension, he's already going to be predisposed there. The counselling, fantastic. And I could see this is, again, something you've obviously done once or twice before. You were very comfortable, were very relaxed, and I could see you really knew what you were talking about there. So I think that was very, very good. And if we jump ahead a little bit then to management options, again, you didn't mention when we were asking about what medications could be useful. He does have already evidence of neuropathy, and so you would consider things like gabapentin, pregabalin, those kinds of medications, but you did come back and add that in later, and so you did end up ticking that box there. But always think when they're asking you questions about kind of management options, go back to what was the patient's presentation, what were they concerned about, because you need to make sure you acknowledge that and tick that box. And you did get there, just had to go back for it. But well done. I can see, obviously, you're doing lots of practice. I can see, obviously, you've seen lots of patients. I think if you just work on that little bit of polish, you're going to absolutely smash it on the day. So congratulations. Well done.
Thank you so much for your all the information. And so just one more question, if you don't mind. For example, when I said the gabapentin at the end, do they consider the score for the previous question, or what they do for the medication, which I forgot to tell?
Yeah. So again, it's clinicians marking this. And so if you display a token of knowledge, even if you've said it in a separate answer, if you've shown you have that knowledge there, it's totally going to count for previous questions as well. Okay. It's not like you have to answer this particular aspect at this particular time. We acknowledge that, again, on the day, stress is high, time is limited. As long as you get the information out and make us aware that you are aware of that, tick, tick, tick.
Yeah, thank you so much for your time.
No worries. I'll leave you to it then. Thank you very, very much for jumping in tonight. And any other questions?
Not really. Just I was when you mentioned about medication, I was just maybe I didn't understand about what the question is. I was thinking you asked me about how you control the sugar. Then I did not think about other medication.
Yes, and so it's intentionally a little bit vague to kind of not give too much away if you haven't acknowledged other bits. So I'll just go back. Where was it? So the specific wording is what medications might need to be adjusted or added to Alex's regimen or regime, considering his current symptoms and history.
Yeah, I didn't.
Sneaky. Yeah, okay. So it's looking at what is he on now, what symptoms does he have, and what might he need for the future. And you got there. You ticked all the boxes. You addressed the diabetes. You had a very sensible approach to upscaling the regime. You touched on different agents and why you would use them as well, which so good. And then the neuropathy. You even specifically named gabapentin as a good agent for diabetic neuropathy. So, yep, well done. Well done.
Perfect. Thank you so much.
No worries. I'll leave you to it.